Vaishnavi, should we start?
Just a second.
Yeah, Vaishnavi. Vaishnavi?
Yes, ma'am. Just a second, ma'am.
Yeah.
Uh, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Sir, you can start. I'll let you know when to start. Sir, you can start.
Dr. Datta, you can start.
Sir, you can start with the session.
Dr. Datta? Yeah, Dr. Datta?
Are we alive?
Yeah, you can start.
So good evening, Dr. Datta Pawar. On behalf of Alkem, all the participants to this scientific session under Alkem's Women's Health Initiative, that is Break the Silence, we are delighted to bring the topic of management during COVID pandemic, which is very pertinent to current situation. And I'm privileged for today's session. Dr. Parikh is saying medical oncology in Mumbai for more than 2 decades. She has done graduation and post-graduate prestigious college Mumbai. She has received her oncology from hospital Mumbai. That is the fellowship. Is visiting consultant to important, that is Bombay Hospital, Hinduja, and special interest of breast cancers. As a faculty at national conferences, she has made publications in national journals. So thank you for joining, and over to you, ma'am.
Can you just stop sharing your screen? Then I can start my screen. Dr. Pawar?
Dr. Datta, you can just move your close your screen. Yeah.
Yes, yeah, I think.
I have closed my screen.
Yes, yes, okay. There we go. Okay. Is it visible?
Yeah.
Okay. Good afternoon, colleagues, and it's indeed a pleasure to be part of this particular scientific program arranged by Alkem. So I am thankful to them, and I'm thankful to each one of you for sparing your valuable time. But I thought that this topic is relevant to each one of us in today's pandemic situation going on. So I'm going to focus today on management of women's cancer during COVID-19 pandemic. As you all are aware that it was March 11, 2020, when the COVID was declared as pandemic by WHO. And this has impacted all areas of our daily life, including medical care. In a developing country like ours, lack of adequate health infrastructure compounded by fear among patients as well as healthcare workers has definitely compromised the patient care, especially in semi-urban and rural population. Cancer care has suffered this setback, particularly as majority of healthcare has been diverted to COVID-19 care. And cancer centers also scaled back their services to some extent, at least last year, that is in 2020, after initial studies showed significantly worse outcome of COVID-19 among cancer patients. So even as oncologists, we were also quite apprehensive, but now over a period of last 1 year, we all have learned how exactly to manage this situation. Let's first focus on ovarian cancer. As you all are aware that ovarian cancer is one of the most common gynecological cancers. And in India, if you go by Globocon data, it is the second most common gynecological malignancies, as you can see in this diagram. The unfortunate part about ovarian malignancy is that majority of women are diagnosed in advanced stages because of little bit non-specific symptoms that they come with, like constipation, abdominal fullness, bloating. So there is always some delay in diagnosis, and hence, unfortunately, most of our patients we see are in advanced stages. If you see this, the particular chart, which is just a conventional management of CA ovary, and in that, of course, once the patient is diagnosed, patient will either go for primary cytoreduction if it is possible, or patient will be started on chemotherapy, and then patient will undergo interval cytoreduction. At the end of it, one may go for second look surgery if it is really necessary. And we also have various options of maintenance therapy today for our ovarian malignancies, which is a topic by itself, so I'm not going to deal with that today. And then if the patient progresses, which many of our patients do, then they would require second line therapy and third line therapy and so on and so forth. So this is how normally we treat our patients. Whenever a patient with suspected ovarian cancer is there, then she should be evaluated by a gynec oncologist. The approaches could be either primary surgery followed by chemotherapy or neoadjuvant chemotherapy followed by surgery. It has been shown in various randomized trials that any of these approaches, if adopted, then the even approach with the neoadjuvant chemotherapy followed by surgery does not have any inferior outcome for the patient. So if the gynecologist or gynec-oncologist feels that the complete surgery is possible, then surgery can be done primarily. Otherwise, one may go for neoadjuvant chemotherapy followed by surgery. If we opt for chemotherapy, the platinum group of drugs definitely are the most important drugs as far as ovarian malignancy is concerned. And we generally prefer giving carboplatin to these patients because the toxicity profile is much better than cisplatin. But this drug also has a tendency for myelosuppression, which is more risky in this COVID era. And this drug is cleared by kidneys. The second important drug for us is paclitaxel, which was initially, of course, derived from a bark of a Pacific yew tree, where the picture is depicted on your screen. But of course, now it is all prepared synthetically. And this definitely helps, by preventing cancer cells from dividing further and growing. But this drug also can lead to myelosuppression, neuropathy, alopecia, and it is metabolized by liver. Not only that, these drugs can also lead to fatigue, nausea, vomiting, etc. Sometimes for some of our patients, we also go for weekly paclitaxel or dose-dense paclitaxel. But certain protocols had to be changed during this pandemic, which I will elaborate later on. If you have a patient who has come to you with adnexal mass where the suspicion of malignancy is quite high, but if you are very sure in this era that pelvic confined disease is present, you may avoid very extensive surgery so that the post-operative stay of the patient is limited in the hospital. I think many of the operating surgeons will prefer open surgeries vis-a-vis any laparoscopic procedures in this era of pandemic. Of course, lymph node dissection has not added any survival benefit for ovarian malignancy patients. All the patients who are in early stages will require chemotherapy, except that patients who are in stage 1 and grade 1 or grade 2 disease. Otherwise, all these women will be receiving adjuvant chemotherapy. In Cochrane meta-analysis of more than 1,200 patients, those who are in early stages, the adjuvant chemotherapy definitely helped in reducing risk of death as well as progression. So adjuvant chemotherapy is very important for survival benefit of these patients who have come to us in early stages, and hence chemotherapy should not be delayed even in this pandemic era. If in these patients who have come to us with early stage disease, there is a limited benefit sometimes of giving combination over single agent carboplatin. And because that we want to avoid severe myelosuppression for our patients, so single agent carboplatin also could be a good choice, but delay in therapy is not advisable. There have been various studies where we have proven that if you're giving single agent carboplatin, 6 cycles should be given. And if you are giving a combination for 4 cycles could be enough, but this is applicable only for very early stages of ovarian cancer. What about advanced stage disease? If patient comes to us in advanced stages, then definitely these patients will not be suitable for surgeries. And this kind of patients should be put on neoadjuvant chemotherapy. And in this chemotherapy, we definitely try and give combination rather than giving a single agent unless the patient's general condition is not permissible or the patient is very elderly or very obese, where the risk of getting corona will be very high. Now, as far as the cytoreductive surgery is possible, then only it should be attempted. Otherwise, very much ultra radical surgery should be avoided for these patients. You all also must be knowing about HITECH, but this also is restricted use, especially in this pandemic situation. If we are using the therapy for advanced stage disease, it is always a combination of pacli-carbo, usually administered once every 3 weeks, and weekly paclitaxel is being avoided so that we can minimize hospital visits of these patients to hospital in this pandemic situation so that they can be safe from corona. But the patients who are at high risk of COVID-19, like elderly patients, comorbid patients with comorbidity, those who are obese patients, all these patients may be considered for single agent carboplatin. There is also some concept of metronomic chemotherapy, that means chemotherapy which is given in very small doses, but this may become a little bit difficult to implement practically. So in that situation, we opt for single agent chemotherapy. I would like to highlight over here that delaying chemotherapy has an adverse impact on the outcome of carcinoma ovary patients. And this survival decreases overall survival by 4% for each week of delay in initiating chemotherapy. So we should not avoid treatment of these patients. We must take all due care. What about emergency procedures? Of course, emergencies are emergencies, and the bowel obstruction, sometimes patient presents with bowel obstructions, and these are the patients who definitely require surgery. And only if these patients turn COVID-19 positive, we will delay the therapy or the surgery. And ultimately, when they recover from COVID, we have continued treatment for our patients. What about recurrent ovarian cancer patients? Many a times the patient comes with recurrence where it is only a biological relapse. What I mean by that is that there is only elevation of CA 125, but there is no actually gross disease in abdomen or anywhere in the body. These kind of patients should be observed. Also, the patients who have come to us with very small recurrences, asymptomatic disease, very slowly growing diseases, these kind of patients may be observed during this pandemic situation. But patients who have got symptomatic recurrence, repeated ascites or certain lymph node masses or some amount of compression symptoms, these patients definitely will require to be treated immediately, and we cannot really avoid chemotherapy for these patients. But when we are selecting a regimen, we definitely discuss the risk with the patient as well as patient's family. And some of them may prefer taking only single agent therapy, though personally as oncologist, we will not, it is not our drug combination of choice. Of course, the patients who have got extensive disease, and if we feel that the chemotherapy is not going to add much benefit to these patients, we only put them for palliative care. The biggest problem as oncologists we have seen is that most of our patients, be it with breast cancer, GI cancers, gynec cancers, most of these patients have unfortunately reported death to us because most of the patients during first lockdown could not either access the medical facilities, or they were so scared of corona that even if they had a small lump in the breast, they have waited till the malignancy has advanced so much that there was a functioning tumor or severe bleeding. So we have unfortunately seen patients who have come to us during this pandemic, usually either in locally advanced stages or advanced stages, and we have missed out the opportunity to cure these patients. As you can see in this diagram, the impact of COVID-19 on ovarian cancer patient is multifold. There has been delay in reporting to the doctors. There is delay in diagnosis because they could not get either appointments of doctors. The diagnostic facilities were not working. Also, there was a delay in treatment because some of them could not access the oncology centers, which were far and flung, and during lockdown, they could not travel. Also, people were scared because anytime that we want to do any procedure or surgery or chemotherapy, we would ask for COVID-19 report. And there were many patients, they only avoided taking the help of medical facilities because they did not want to undergo COVID-19 test. So I'm sure that all of you face this issue. Also, then they opted for alternative treatment management, and then they presented to us with late stages. And of course, quality of life was definitely affected, I think, for each one of us, because there is worry, depression, anxiety, and so on and so forth. So there is a tremendous impact. Now, as far as the Indian guidelines are concerned for ovarian cancer, as you all know, as I discussed in my previous slides also, in early stages, one may opt for only single agent carboplatin, but combination is preferred. And those patients who have to go for neoadjuvant therapy, and if they have a high risk for COVID-19, they may again be treated by single agent carboplatin, but we will prefer giving paclitaxel. Symptomatic recurrence should be treated, and metronomic chemotherapy combination or single agent also can be considered. How are our guidelines compared to European Society of Medical Oncology guidelines? They're almost similar, and we are almost following the same things. We also try to give our patient colony stimulating factors after taking chemotherapy, basically to prevent myelosuppression, because it has been seen that when the patient is myelosuppressed and if they catch corona, the outcomes are really poor. So we are giving chemotherapy, but most of our patients will be receiving prophylactic GCSF. We also try to reduce use of dexamethasone so that immunosuppression can be avoided. For ovarian cancer, if by any chance the patient is BRCA positive, BRCA mutation positive, we have oral tablets available of olaparib, and we can also treat them with that, and we can probably avoid chemotherapy for these patients. So these are some of the choices that we have today. And of course, chemotherapy still remains the backbone of all the patients. But if the patient is elderly with pre-existing comorbid conditions, respiratory problems, then these are the patients where we have to be very careful before we actually start chemotherapy. What about cervical cancer? All the early stages cervical cancer may be amenable to surgery, but as you are aware that there has been tremendous delay in diagnosis, we must start treatment without delay, because it has been shown that if there is a delay, then it leads to 1% per day decline in local control. And local control is so important in CA cervix, as you all are aware. So early treatment is definitely necessary. Diagnostic procedures also ideally should go ahead as we do in non-pandemic time. Many of our surgical facilities were closed in last 1 year, especially in the complete lockdown in 2020. And at that time, even if some of the operable patients were referred to us actually for chemoradiation because those facilities were open. And we have treated many of these patients by giving them chemoradiation, which also should be started in time. No delay should be done as far as possible. And these patients can be treated with minimum number of radiation fractions. We tried to treat them with 45 grain, 25 fractions, especially if they had early stage node negative disease. But of course, those patients who had extensive disease, they need to be given radical radiation also. The radiation therapist also tried to use little bit less complicated radiation machines so that patients spend less amount of time in each radiation facility. Those who are young, we have also considered them for concurrent chemoradiotherapy, because we know that concurrent cisplatinum is associated with 10% absolute improvement in overall survival for all these patients. So we do not want them to suffer recurrences in future, and hence we have also considered them giving chemoradiation. Of course, the cases where they are locally advanced, no doubt they need to take chemoradiation. And we know that the absolute benefit of almost 9 to 10% in progression-free survival as well as overall survival at 5 years has been published by Tata Memorial Hospital, Mumbai. And we should not avoid chemotherapy for these patients, as the pandemic will ultimately go, but the patients are going to be there. So we want to give them best care as far as possible. Brachytherapy was challenging during this time, and there were many patients either they could not access brachytherapy facilities, or sometimes it was difficult to give brachytherapy to these patients because of the COVID problem, sometimes lack of technicians also in the radiation therapy department. But still we have tried to give it, and we have tried to reduce the fractions of brachytherapy for these patients. So as far as Indian guidelines go, again, same way, that if surgery alone can suffice, then we may do it. But in this situation where it is not possible, then or locally advanced disease, chemoradiation should be given, and it should be started quickly. And concurrent cisplatin is necessary, and we should not avoid that unless the patient has a high risk of COVID-19. And palliative treatment should always go on for all our patients. Similarly, even for European Society of Medical Oncology guidelines also, if you see, all the patients who have come for first line therapy, those who are in early stages, and even metastatic setting first line, they all should receive priority treatment. Those who have come for recurrences, second line therapies, where the chemotherapy may not add for a very prolonged benefit, they may be put in low priority. So this is how they actually treat their patients. But I sometimes feel that even the patient who has come for second line therapy, her life is also equally precious. So whether we should really put them in low priority. And I feel that we should try and treat all our patients equally. What about endometrial cancer? Of course, surgery is an extremely important step as far as endometrial cancer is concerned. All of you are aware of this staging and guidelines. And if you go to see the treatment for adjuvant therapy also, of course, as you can see that very early stages disease may just be observed, or patient can only receive brachytherapy. But if the disease is slightly advanced, say stage 3, 4 or late stage 2, one might have to consider them even giving chemotherapy for this patient, as we intend to cure these patients. And as far as our Indian guidelines go, in operable endometrial cancer, surgery can be deferred at the most up to 6 weeks, but we don't want to do it, honestly speaking. Adjuvant radiation also should be given in all high-risk cases and only omitted for very early stages. In inoperable cases, one may go for radical radiation with brachytherapy or even progesterone treatment since they are ERPR positive, but this may not be the ideal treatment. And in advanced stages, again, palliative therapy with chemotherapy. Here also paclitaxel and carboplatin is the drug of choice for these patients. But those patients who have a high risk of fatality with COVID-19, elderly population, we may consider them giving them only progesterone or palliative radiation. But we do not want to actually deviate too much from the standard protocol and we want to stick to them. Similarly, even for European Society of Medical Oncology guidelines, again, say they have put second line chemotherapy patients in low priority and those who have come to us with the first line therapy treatment as high priority, but we must try and give our best to our patients. So if you just see this flow chart, most important thing is that what is the risk of COVID infection? And we are aware that all symptomatic individuals and those who have taken international travel in last 14 days, those who have come in contact with laboratory confirmed cases or even some of the healthcare workers who are symptomatic, all these patients may have high risk of COVID infection. In that case, triage is a very, very important part of our hospitals today. We must screen all the patients who are entering our hospital in triage and then divide them into low risk and high risk. If you have the low risk category patient, then you may consult and investigate them in PPE, not in full PPE, then at least in level 2 PPE. If they are in high risk again, then they may will go for consultation as well as investigations, of course, but with all due PPE care. These days, we also try to do virtual multi-speciality board meetings with all the specialists available virtually so that patient doesn't have to go from one doctor to the other and we can finalize the management at the same time. And we take consent, including risk for COVID-19 infection is explained to each and every patient who is coming for chemotherapy or any other treatment. And consent has been taken and they have been informed that if they get COVID-19 infection during the treatment, the risk of complication is higher. And of course, a CT chest will be done even as a part of the staging, but otherwise also it should be done. And we have to rule out any pneumonia or anything before we start any treatment. And the treatment guidelines as already written over here, we have followed almost the same. In this chart, it is mentioned about HCQ prophylaxis, but that's a debatable thing. As you know, actually, I have not put any of my patients on HCQ prophylaxis. What about breast cancer patients? This is the standard treatment overview of breast cancer. Most of you are aware of this, that if you have a very early stage disease, that also luminant A type, that is those who are hormone receptor positive diseases, they can go for initial surgery followed by chemo and radiation and anti-estrogen therapy, which is a standard treatment. And there could be patients who are high-risk patients, like those who have HER2 positive disease, those who have got triple receptor negative breast cancer. Now, these are the patients where we may also consider giving them neoadjuvant therapy first to improve their outcome. We'll give them chemotherapy, and those who are HER2 positive, we will definitely give them anti-HER2 therapy. Once we have achieved adequate response, we are going to give them, we'll take them up for surgery and followed by continuation of further treatment in the form of either chemotherapy or radiation or even hormone therapy, anti-HER2 therapy, depending on what kind of breast cancer that you are dealing with, because breast cancer is a highly heterogeneous disease and we are individualizing treatment for our patients these days. And it is not a one size fits all kind of an approach. So again, this is a similar kind of a pictorial representation of the standard treatment that we are giving to our patients. And I'm happy to say that we have been able to stick to the protocol for most of our patients in spite of there being pandemic. So why are we trying to stick to the protocol? Because in chemotherapy, it has been seen that the drug intensity is very, very important. The total amount of drug that the patient is receiving is important. The patient receiving chemotherapy, what is the amount of dose given per week is also equally important to cure these patients. This is just a pictorial representation of what kind of impact this pandemic has had on various malignancies. If you just see this chart, for colorectal malignancies, the excess of death is to the tune of 2%, which will probably go down later. While for breast cancer, the excess of death just because of the pandemic effect is almost to the tune of 3 to 3.5%. When we see the percent, we may feel that it is small, but when you see the large number of patients who get this malignancy all over the world, this runs into hundreds of patients. So we definitely do not want to do this to our patients. Now, as far as the European Society of Medical Oncology guideline goes, they are almost similar to ours, what we are also following. And they have also, what we are trying to do is that many of our patients of breast cancer are on weekly therapy with paclitaxel. So they have to come to the chemotherapy unit every week. So all these patients, we converted them into 3 weekly dosing, because of which their hospital visits were reduced. And also at the same time, we have given them prophylactic GCSF so that these patients don't go into myelosuppression. If they were on LHRH analog to create ovarian suppression for ER positive diseases, instead of giving them monthly therapies, we have put them into 3 monthly therapies. We have also tried and see whether the oncology nurse can go to their houses and they can dispense the medicine. So this is what we have tried to do. And telemedicine today has formed a very important part of our practice. I think all of you will agree with this. Of course, in oncology, sometimes it is restricted only for the follow-up patients, but any new patient or the patient who has an active disease, we have to see them in our clinics. Similarly, if you go to see even for metastatic breast cancers, we have tried to give oral chemotherapy if it is possible. We can give oral chemotherapy in the form of capecitabine for some of these metastatic breast cancer patients. Similarly, if it is possible, we have tried and used hormone therapy maximally for all hormone therapy, hormone receptor positive breast cancer patients, as we have various agents available, including aromatase inhibitors, tamoxifen, fulvestrant, and we also have targeted tablets available in the form of CDK4/6 inhibitors. So all these things put together, we are able to manage our patients with oral therapy if it is permissible, of course. But we have to remember that these patients also still could be prone to infection. So all the care needs to be followed, because CDK4/6 inhibitors also lead to neutropenia. So this patient needs to be monitored. At the same time, we have various other agents like PIK3, CA inhibitors and all. They also can be used because they are also oral preparation. So what are the general recommendations? Now, these recommendations have come from American Society of Clinical Oncology to minimize the risk of COVID for our patients. In general, patients with cancer should self-isolate. They should be restricted to home as far as possible. Screen the patient by phone before they visit our clinics or our hospital. Screen temperature and symptoms at the facility entry. That is, triage is very important. And for outpatient patients, we can avoid unnecessary visits. We can use telemedicine, and we can have a system where we can get the laboratory testing or other imaging also done near their houses, and they can upload their reports and we can consult them, especially if they are only for follow-ups. And we can always have a home visits facility available by our oncology nurses, so that symptom management can be done and also medicines can be dispensed. As far as, of course, inpatients are concerned, we must have, obviously it goes without saying that we should have a separate ward for our patients COVID positive and 19. We must use PPE, at least level 2 PPE, if not full PPEs, and frequent hand washing, all hygienic care, disinfection, and limit visitors. As far as possible, relatives should be avoided from entering the hospital. Many of the hospitals stop visiting time, of course, which is the wise thing to do. And by any chance you are dealing with an infected patients with, I think many of the obstetricians who conducted deliveries with COVID-19 positive patients, they must have a facility for negative pressure or HEPA filter in their wards. So this is something important. And as far as Indian guidelines for setup for oncology units, and we must have COVID-19 free unit where all the patients who require treatment and they all anti-cancer treatment must be started immediately as far as possible. Triage should be provided for all the patients, but limit the visits to the hospital, and only patients currently ongoing treatment should be encouraged to come to the hospital. Follow-up visits should be either avoided or should be done virtually. Screening facilities were also stopped at some of the facilities. All the patients should be tested for COVID-19 before initiating any immunosuppressive therapy or even surgery or radiation for that matter. And all healthcare workers should wear PPE all the time. And as I said, that we conducted actually virtual meetings for our patient in the multidisciplinary board, so that we can give instant and prompt decision for the patient that what exactly needs to be done. But the patients who are more than 70 years old and those with comorbidities, they should be considered for high risk for corona, and subsequent therapies could be guided accordingly. What about surgeries? In initial phase of the pandemic, especially in 2020, surgeries were not done. And but ideally for all oncology patients, surgery forms a very, very important part of the management. But of course, maybe laparoscopic surgery could be avoided. And of course, now anesthetic surgeons all are in forefront. They are taking care of themselves and the patients, and they are doing all the surgeries and all. But it was a little bit of a setback in pandemic during 2020. One of the most important questions which is there today, what about vaccines? So whether we should use vaccines for cancer patients, that is a dilemma for many physicians and also for patients. At this time, patients with cancer may be offered vaccination against COVID-19 as long as the components of these vaccines are not contraindicated. So if you see the vaccines which are available with us today, that is Covaxin and Covishield, these can be given safely to all our cancer patients, and we motivate all our patients to take vaccine. So unless there is a specific contraindication written in the vaccine, there is no need to avoid vaccination for our patients. But before we give vaccine to our patients, we counsel them that we do not know the exact safety profile and effectiveness in cancer patients, as there is no data. It is a new vaccine. And we also explain to them that because of their own decreased immunity, they might have reduced immune response to COVID vaccines as compared to general population. But still, I personally feel that these immunocompromised patients should take vaccine, because at least they can prevent the severe form of COVID infection, and the death also can be avoided, which was seen initially in last lockdown in 2020. So definitely we want our patients to take vaccine. So the question is that those who are undergoing chemotherapy or radiotherapy, whether they should take the vaccine. Yes, now majority of us have enough experience in providing available types of vaccine to our patients who are already on chemotherapy, immunotherapy, radiotherapy, or even stem cell transplant. The general recommendation, what we do for our patients who are on chemotherapy, we tell them to take vaccine only when their CBC is normal. Complete blood count should be normal when they take vaccine. So normally I tell them that they should take 2 days before their chemotherapy, they can take CBC. They can inform me the report. If the report is okay, they can take the vaccine, no problem. But then we avoid giving chemotherapy for about 2 days. Only for the reason is that if the patient develops fever after taking vaccine, then it can just mix up the picture when I have given the chemotherapy to that patient. Hence, I would just like to wait for 48 hours. And once the patient is fine, we continue giving them chemotherapy. And even for the patients, only thing that patients who have undergone high dose chemotherapy or stem cell transplant, probably these are the patients where we are still avoiding giving vaccine. So that is very important, but all standard dose chemotherapy patients should take vaccine. What about the vaccination for our cancer survivors? Many of our patients whom we have treated a few years back, they all call us whether they can take vaccine. Even there are patients who have taken treatment from me 10 years back, 15 years. So they are contacting us whether they can take vaccine. And the answer should be yes, that yes, they all should take vaccine. There is no problem at all. And only those with, if there is a specific contraindication written in the literature of the vaccine, we should not avoid vaccine for anybody. So I would also like to I would also like to share with all of you how actually I manage my cancer patient. As I said that when the pandemic was declared and we all went into strict lockdown last year, April onwards, initially all of us were hesitant to treat the patient or even to go to the hospitals. But April, May, June were a little difficult, but ultimately we gained confidence of treating our patients, and I have continued treating all my patients. But of course, try to reduce hospital visits. Obviously, I think all of you have done the same thing, that we try and combine our patients either in one hospital or you just go to 2 hospitals, try to combine your outpatient, inpatient together and try to prevent even our own exposure in the hospital setting. I must admit that we all have become more confident now of managing how exactly to navigate for our practice also. I have tried giving oral medications as far as possible, as far as for metastatic CA breast patient or those who are on breast cancer, even adjuvant therapy I have tried. Also, there were some patients who did refuse taking chemotherapy, especially last year, as the fear for COVID was very high. But now we all have realized that this pandemic is not going to go away easily, and we cannot really compromise outcome of our patients. Hence, we have also become more confident, and patients have also become more confident. Of course, I have used teleconsultation whenever personal visits were not required. For most of our follow-up patients, I have used teleconsultation. But of course, new patients, critical patients who are on chemotherapy and develop complication, all these patients need to be seen in person. Now, all the precautions for corona were definitely taken at the hospitals or in the outpatient, while spacing the appointment, by cleaning the couches when you're seeing them in the OPD, and hand hygiene and complete mask. And also relatives also, we have restricted generally only one relative with every patient for indoor facility or outdoor. Actually, in oncology, generally with one patient, at least 2-3 relatives always come because everybody's anxious and they want to discuss. So what I do is that I call only one relative, immediate relative member, family member who knows everything about the patient. And then the remaining relatives can take teleconsultation from me so that they understand the seriousness of the problem. But there is no point in, crowding our consultation rooms. In spite of taking all this care, of course, 20% of my patients approximately, they got infected with corona, and they had to be, some of them were admitted, but not all of them. Some of them unfortunately got it when they were myelosuppressed, so they had to be admitted. Fortunately, all my patients recovered from corona, and they continued their treatment after recovering. But some of my colleagues, they did lose their patients also. Triage and COVID-19 negative report are absolute must before any admissions. We are not obviously doing it COVID-19 report for any outpatient consultations, obviously. Protect all the healthcare workers, and training of our nurses, training of even ward boy and all, everything is very, very important. So they protect themselves and also they protect our patients. And I have motivated all my patients and their caretakers to take COVID vaccine. Most of the caretakers are very, very enthusiastic to take the vaccine. So, but I tell them that, yes, okay, you take vaccine first, but ultimately patient also needs to be vaccinated. Now, vaccine is also available more freely, probably at many centers and hospitals, private as well as public. So I'm hoping that ultimately most of us are vaccinated, including all the healthcare workers, and we reach at least herd immunity somehow. And that is how we all should be able to take care of our patients safely, even if this pandemic will probably go on for a few more months. So I thank you very much for your patient hearing. Have a safe year ahead. And of course, as I mentioned, promote vaccine to all, because that is the only solution to this particular virus. Thank you very much. And I will be happy to take any questions from now on.
Thank you, ma'am. Thank you very much for this wonderful presentation. And you actually covered all the aspects about how to manage these patients in COVID situation, what has been changed in this scenario. So now I request all the fellow participants, gynecologists, to put their question in the chat box. So there is one question, ma'am, has come. How should a patient manage early diagnosis of gynecological cancers during COVID-19 infection?
Okay, so this patient, say for example, if we have any patient, say for cervical cancer malignancy, most of these patients may come with bleeding PV complaints. And if such a situation arises, as I said, that with all the due precaution, even in the outpatient, we definitely need to examine this patient per speculum examination may show growth, or one may do a smear, and colposcopy facilities, if they're available, then they should always be done. Regarding the, if the diagnosis is established, then the quick staging procedures like MRI pelvis, etc. should be done. Of course, CT chest will be done even as a part just to rule out the COVID infection in addition to, of course, RT-PCR. And once staging is done, by any chance, if the gynecologist feels that this patient is still operable, now I think most of the places surgeries are going on regularly, and in that case they may be operated. Otherwise, we should definitely not delay the treatment, and at least the chemoradiation should be started for all these patients. No doubt about that.
Thank you, ma'am. And there is another question: if the patient is newly diagnosed with breast cancer, should she take COVID vaccine? And the related question to that is, if the patient is having a metastatic disease, then what should be the status on this COVID-19 vaccine? Is there any?
No, whether the patient is in early stages or late stages, they should definitely take vaccine. There is no problem about that part of the story. In fact, if patient is an early stage breast cancer and my colleague operates, then there is a gap of about 4 weeks to 5 weeks before starting chemotherapy sometimes. So if the patient is a patient's suturing, healing, everything is okay, the surgeon is okay, then I tell the patient that you take 1 dose of vaccine before you start the chemotherapy, because after that the lady will become immune suppressed. So they will take 1 course, and now, as you know, as per the latest guidelines, the second dose is given only after 84 days. So that will be almost again another say almost 2.5 to 3 months. So by that time, this lady would anyway finish about 3 cycles of chemotherapy. But once you have taken at least 1 dose also, the antibodies start forming. And patients and relatives usually take good care for the corona, because obviously they are aware that there can be a problem. So I personally feel that these patients, whether they are in early stage or late stages, they can definitely take the vaccine. Only thing that we need to just time it well, so that it should not be given, say, on the day of chemotherapy, previous day of chemotherapy, because the vaccine itself can lead to fever or sometimes fatigue or muscle pain. So we don't want to compound the effect of chemotherapy as well as vaccine for a patient. So I always tell them to take about 2 to 3 days before the chemotherapy cycle is due.
And ma'am, one question regarding what if the patient is having a lung metastasis and got infected with SARS-CoV-2, then should that patient receive myelosuppressive chemotherapy or any other chemotherapy, or what should be the line of treatment in that?
You mean breast cancer patient?
Yeah, breast cancer.
Assuming, So you are trying to tell me that patient got COVID infection when she was diagnosed also with metastatic disease. That is what you are trying to tell me?
Yeah, lung metastasis and got infected, because that will complicate.
Yeah, so most important priority in acute problem is COVID infection. That lady has to come out of that COVID infection first. So these kind of patients are definitely admitted. There is no question about that. So they will be admitted in the COVID hospitals, and they will be managed. Now, if this lady definitely comes out of this COVID infection and then she comes to me for treatment, for metastatic disease, what I normally do is do the biopsy and see whether the ERPR HER2/neu is positive. Because if this lady has ERPR positive tumor, metastatic breast cancer, then I can treat her only by hormone therapy, and I don't have to give chemotherapy to her. So that will be something very important. But first and foremost is that she needs to come out of COVID infection, because when there is an active infection, say first 2 to 3 weeks, we definitely cannot give any anti-cancer therapy. So that is out of question. But hormone therapy could be one option for such a patient if ERPR is positive. I mean,
that is safe to give in that case.
Yes. Yeah.
If that is TNBC, if it is HER2 positive, obviously trastuzumab, can it be given?
Yes, trastuzumab can be given, and in that situation, because see, we have to realize that all the breast cancer patients HER2 positive, these are aggressive malignancies. So once we have proven that she is now RT-PCR COVID negative and her saturation is okay, she's maintaining saturation and doesn't require oxygen support, those kind of patients, we will discuss the chemotherapy part with the family and the patient. If she is HER2 positive, then I will definitely do anti-HER2 therapy. And regarding the chemotherapy, either we can opt for any single agent safe chemotherapy, or those patients can be given capecitabine, oral chemotherapy, along with anti-HER2 therapy. So the capecitabine she has to take at home. And only for anti-HER2 therapy, once every 21 days, this patient has to come. The problem comes, of course, for TNBC patients, because TNBC is again extremely aggressive kind of breast cancer and cannot leave them without treatment. And only treatment which will work for TNBC averagely will be chemotherapy. And so these kind of patients, again, same way, if this lady is not oxygen dependent and other vital parameters are okay, then I will consider her for chemotherapy, but then maybe I will just give her some single agent chemotherapy to begin with. And only if really necessary, I will put her on combination. Otherwise, single agent chemotherapy should work well, say something like Texans also. And even for TNBC, something like cisplatinum or carboplatin also works well. So these are the kind of drugs that I would like to use.
So considering this current situation, many patients misdiagnosis, early detection of be it a cervical cancer or any other cancer, breast cancer, the chances are missed. So what should be done to improve the early detection in such situations? Like what can be advised to any patient coming to the gynecologist for any other thing? So what should we look into to make them aware to like get early diagnosis
Yes.
in this
See,
situation?
yes. So I actually all over the world in last 2 years, all the screening procedures have gone for a toss, because screening is done for, say, asymptomatic individual. So once somebody is asymptomatic, they will not come to the hospital or any diagnostic facilities. So unfortunately, the screening which is there, whether it is mammography for breast cancer or whether it is pap smear and all those things, so everything has gone for a toss all over the world. So that is why we are getting patients who are now already having the disease. And number two, unfortunately, as I mentioned in my talk also, we are getting patients who are in advanced stages only. Very few early stage patients are actually coming to us. We have patients who had a small tumor last year, and now they have come to us by January with fungating masses from the breast or locally advanced diseases, say whether it is for CS cervix and etc., or even other malignancies for that matter. So it is really sad to see that we have missed that window of opportunity where we could have cured so many patients. So the factors, the causes are many. The most important thing is fear due to corona. So hardly any patient or relative wanted to visit any medical facility, though they knew that this is a thing. Even if they visited us last year and we advised for biopsy, they didn't want to go for biopsy. Because they got scared that because obviously in most of the facilities before doing biopsy, COVID-19 report was asked for. So the fear is that if my COVID-19 report comes positive, then what will happen? So because of that fear, people have avoided coming to hospital, going for biopsy, or even going for CT scan or any staging procedure that we asked for. And because of that, unfortunately, we are getting all a delayed diagnosis. So only option left for us is that we vaccinate maximum number of people, we remove that fear from their mind, and then restart our screening facilities. There are many facilities where hardly any screening is done today, even now.
The guidelines which recommend that only high-risk patients should be tested for COVID-19 for if you want to go further with management. What if the patient is coming to OPD for whether it is for routine gynecology consultation or even for the want to get tested for anything in cancer OPD? So all these patients are advised to go under COVID testing, COVID-19 testing, or how is it? Means
for all our outpatients, we are not doing obviously any COVID test. But so that is why triage is very important. Because see, ultimately we need to protect ourselves also. And we also need to protect our staff, even our ward boy, Ayabai, whoever is working with you. So we have to make sure that before the patient actually comes inside your chamber, the patient is already screened at the entry. So most of the hospitals have a screening facility where they will take the saturation, they will take the temperature, they will ask for symptoms of COVID, and then only they are allowed to go. In fact, most of the hospitals or the clinics, they have two facilities. One, some of the clinics are able to call up the patients on the previous day, take their history. Also, they take history of travel, because see, there are so many patients honestly speaking, they even hide the history of travel if they come from outside. Just now, the most of the airlines are stopped and also it's a different scenario. But initially, we have seen patients coming from Gulf. They said the RT-PCR over there was negative. When we have done here, most of them were positive. So these are the practical things which are happening. So for the smaller clinics, what we are doing is that our assistant calls up on the previous day, takes proper history, asks for all the symptoms, etc., and then confirm their appointment. We try and give a gap of at least 10 minutes between two appointments so that there is no crowding and overlapping in our clinics also. As far as the another facility which the bigger hospitals have, that each one of them is having this screening facility at the entrance only. The nurse will be sitting over there. So she'll ask the history, take the temperature and saturation, and then only allow the patient to come in. So some of the hospitals are giving the paper in writing where they will take mark green. That means they're allowed to go inside in our green area. Green area means non-COVID area. And if they find any suspicions, then they are sent to red emergency. Red emergency department is where you can send your suspect patients and then they will be actually screened for COVID first, and then only they will be allowed to enter. As you are aware that BMC actually took over most of the hospitals where almost 80% of the beds were converted to COVID. So throughout this pandemic, in all my hospitals, I worked in a mixed population of COVID, non-COVID, but all the hospitals have strict guidelines where the buildings are separate, entry, exit are separate, and also the emergency rooms are red emergencies for COVID, green emergency room is for non-COVID. So we have followed all the protocols strictly and we have tried and avoid contamination as much as possible. So this is how we are managing on our day-to-day basis. And of course, before I forget, we are wearing level 2 PPE in our clinics, which will include your gown, N95 mask, gloves, cap, and at least preferably a face shield. Because we all know that the entry point for corona is oral cavity, nose, and eyes. So we have to protect our eyes. So that is also very important.
I guess you have got most of the questions which are asked here. So thank you, ma'am. Thank you very much for this wonderful presentation, and even you cleared most of the doubts which were there and questions asked by the gynecologist. Vishaka, is there any question, further question? Because most of the questions which are there are already answered.
Yeah, there is one question which I've posted last in the chat group.
Okay, which group of cancer patients should be screened immediately or for? So I think that has already been covered by Dr. Parekh.
Okay.
So I think that's it. So thank you, ma'am. Thank you very much once again. And I would like to thank all the participants who have joined from their busy schedule. And I would like to thank ma'am also to joining us, taking the time from busy schedule and making this session very wonderful. Thank you once again. And that's it.
Okay. Thank you very much.
Thank you, ma'am. Thank you so much. Thank you.
Pleasure. Thank you.